My name is Paul Klein. I'm privileged to serve as the chair of the Diversity Committee for the Graduate School of Social Work. And on behalf of our committee and Emily Griesing and the Alumni Association, we welcome you back to campus for this conversation. I think if I had to describe in the most simple terms what it is that our diversity mission is about here in the School of Social Work, it's to keep the conversation going and to make sure that we're always talking about the ways in which social workers are obligated to engage people in the fullness of their identities, respecting and understanding and working within the unique context of their ethnicity, their race, their gender, their sexuality, their social class. And so it's important for us as practitioners, as students, as faculty, as alumni to support each other in what can sometimes be a challenging and difficult but always rewarding conversation. This morning we'll have two conversations, one of which will explore the unique developmental experiences of older adults who are sexual minorities, and also the experience of immigrants and refugees who are older adults. Our first host for this first session, is Susan Tone. I think everyone here probably knows Susan, and many of you have probably spent time with her in the classroom. She is a gifted teacher, she is the chair of our clinical sequence, and we're very fortunate to have her as the host of this session. Susan.
Thank you, Paul, and good morning. So it's really my privilege to introduce Lisa Krinsky. I've heard about her for a long time. Katie McGinnis-Dietrich has talked about her for a long time. So I'm really, when I got to talk to her on the phone and talk about what she'd be doing with you this morning, it was just really exciting and I think a challenge for her because she has such vast experience. To think about what she was going to do in 75 minutes is really hard. So I think she's put together a really exciting program for us that's going to give us information and then stimulate and challenge us to think about how we could apply that information. So you'll really walk away thinking, I would do something different now than when you walked in the door this morning. So I think that's really exciting, and I am very grateful to her to being so thoughtful about this. So Lisa has incredible years of experience. She graduated with her MSW from Simmons, but she's got over 20 years of experience working with older adults in elder care. She's got this national and local experience doing presentations and being an advocate around policy. She's worked at the LGBT and Aging project for over 9.5 years. So she's truly an expert. I'm not going to talk anymore because you really just want to hear from her. So let me just introduce Lisa Krinsky.
Good morning, everybody. It's a pleasure to be here, and thank goodness this isn't last Friday morning, right, when the blizzard or whatever that was struck us. So I am so pleased to be here to talk with you, those of you who are current BC social work students and those of you who are former or lifelong learners, right? Isn't that what happens to us? I'm in my second year of having my second fabulous social work intern, macro student with me at the Aging Project. So I'm working closely and really enjoying having one of your students work with me. So what I would love for us to do this morning, first what I want, just a quick show of hands. How many of you know that you have worked with LGBT older adults? Interesting. How many of you don't know that you've worked with them? It was a trick question. Anyone who didn't raise their hand the first time should be raising your hand the second time. And we're going to be talking a little bit about this issue around invisibility and identity and those kinds of things as we move forward. So one of the things that I do want to do is I want to introduce you to some of my friends before we get started. I think that it's always important to have real people, real faces, real stories that you can connect to so that what we're talking about is not just an abstract idea. What I love about the film is I think that it spells out in very real terms with very real people's stories a lot of the experiences and the history and the current experiences for LGBT older adults. And so with that said, I want to spend a little bit of time. I was just thinking, I'm trained as a clinical social worker, but I tend to live mostly in a macro social work world, and so I'm going to do the big taboo and kind of live in between both places and not be so siloed, which is actually very much what we do at the Aging Project. I guess my life is about intersections, and so one of the things that we do at the Aging Project that we're really committed to is really working with and being that bridge and that intersection between the LGBT world and aging services and elder services and what happens in those points. So just really quickly, the Aging Project came about over a decade ago because there were many of us who have worked in elder services here in Massachusetts who realized that we have a tremendous system of care for older adults, whether it's community-based, residential, whatever that may be. And we do such a good job of taking care of older adults. And that being said, LGBT folks were nowhere on the radar screen. At the same time, the LGBT community had been so committed and so focused on the issues impacting the community, like HIV and AIDS, like youth suicide, marriage equality took over our lives for a period of time, transgender issues, bullying, all of those kinds of things, that, surprise, surprise, there were no old gay people. Didn't exist, right? And so what we realized was that there was going to be, and there was and was increasingly going to be, this intersection of LGBT older adults that nobody was thinking about, just not on the radar screen, and that's where we came about. And our mission really has been to ensure that LGBT older adults have equal access to what's already out there. We're really not intent necessarily on creating different service delivery systems, on creating silos, but more saying, you all do a really good job in the work that you do. You've got excellent skill sets, and we want to make sure that you expand that capacity, that in a broader way that you're mindful about LGBT older adults and figuring out how they can have the most positive experiences in whatever way you may be engaging with them. I just said that. I always jump ahead of that slide. Just really quickly, as we talk about these topics, lesbian, gay, bisexual, we're talking about people's sexual orientation, who they're attracted to, who they partner with. And when we're talking about folks who are transgender, we're talking about gender identity and expression. That stands alone within each of us and not about being in relation to other people. So I want to cover some of the basic facts, that questions that I get very frequently. How many of these people are there? Who are we talking about? Well, one of the things that's really powerful is that we don't, if you think about all the paperwork of life that we're always filling out, we don't collect this data in any consistent and regular way. Think about whenever you have to fill out a form or you have to fill out a form with or on behalf of a client, when are you ever asked any information about your sexual orientation? You're asked gender, and you're usually given two choices. You can check male or female, so if that doesn't work for you, you're out of luck. There's no box for you. But we never, rarely, sometimes people say maybe a doctor's office might be asking or something like that. What we know that is so powerful, that is, if you are not counted, you do not count. If we do no data collection, and we can't talk about a population, you basically just have to trust me on this. And I was just up late last night working on a grant and thinking, 10 years into doing this work, trust me, is not cutting it anymore with funders. And so we really need to think about, how do we document who exists? And this obviously applies to many other undocumented and invisible populations. So the 2000 census was the first time that we actually had, on a large-scale basis, the opportunity for individuals, if they chose to self-identify that they shared a household with a same-sex partner. So if you were willing to check a box off and to tell the federal government that you shared a household with a same-sex partner, here's the data that we saw at that point, which is that of the folks who responded, and I think it was up in the 97% of the population respond. 97%, no, LGBT folks were in 97% of all the counties that reported back. So this wasn't a Jamaica Plains, Somerville, Provincetown, New York, San Francisco kind of thing. This was practically every county everywhere. But we found that 1 out of 4 same-sex couples had a partner over 55, and 1 out of 10 had a partner over 65. Those were the people willing to tell the government that they're out there. Now, has anyone ever met a single lesbian who lives alone? Anybody? You have? Good. You may even know somebody or whatever. Okay. You don't exist on the census. This is about shared household. If you do not share a household with a partner, if you live in 2 separate places, we don't capture you in the data. So again, just thinking about how that connection and how much of an impact that has, if we're not gathering and capturing and identifying you, both asking whether you exist and creating an environment where it's safe to report that, We then don't have numbers. If we don't have numbers, you know that we can't do programming and we can't reach you. What we do when we sort of play with lots of numbers about the growing population, older adults in general, is that we can estimate at this point that there are probably about 30,000 LGBT older adults in Massachusetts. No, I do not have a list of who they are and how to find them for your outreach program. That's the other question I get a lot. So please close your right eye and look on the left side of the screen. These are most of the issues that people in general who are working with older adults encounter. So most people who are aging are thinking about health care. They're thinking about, we know all about the health care stuff going on. Do I have adequate access? Do I have adequate housing? How much am I spending on medications? Who am I spending my time with? Who's my social fabric, my social connection? Do I have family? Am I in relationship with them? Are there friends? What am I doing that's meaningful and purposeful in my life? Am I still working because I want to? Am I working because I have to? If I'm not working, what do I do with myself? How do I not become sort of relegated in our culture to just being an old person that's not valued? What do I do that's meaningful for myself and meaningful in community? So, are there special and unique things for LGBT folks? Look on the right side of the slide. You'll see that these are the same issues that LGBT older adults are facing. However, when we talk about a bunch of cultural and social and all sorts of historical factors and life experiences, we'll find out how these particular issues are impacted by that experience of being an LGBT person in our culture. So this is a really powerful slide, and the previous message I just gave to you is the issues are pretty much the same. Now I want to say to you, there are unique and distinct factors for LGBT older adults. So if you compare the general population, which is the darker upper numbers that are listed here, with what on my screen is a lighter purple color for LGBT folks, what are you seeing? Our folks are significantly more likely to be aging alone, both living alone, not having a primary partner, and not having children. And for those of you who have experience working with older adults, you know that partner in the home, anybody in the home, and adult children are important elements of a care network for providing care for somebody. So if I have more people in this population particularly who are living alone, we know that we are going to see increased health disparities on a variety of levels. We know that we are going to see people are at greater likelihood for depression, up into and including suicidality. We may be seeing increased levels of substance abuse, social isolation, physical conditions that are not cared for and attended to as well, and poor nutrition, and also, what we tend to see is that for those folks who are aging alone without that support network, what we like to think of as sort of premature institutionalization, that people will need a formal network of care or residential care or something like that sooner than folks who have that network around them. So you would then think that if this is a population that doesn't have as much of an informal support network as the heterosexual population, that these are the people who really should be showing up in the service delivery network, right? So are you seeing a lot more LGBT folks, disproportionately a lot more folks in your service programs because they need it more than the other people? Most times people say no, we're really not. So what's happening where potentially there's greater level of need, and yet on the ground, providers are saying, I'm really not seeing these folks? I would say they may already be there and you don't know it, and that they're not coming through the door because there isn't a sense that you are really going to be a responsive resource for them, regardless of sort of what good intention you bring to it. That's a difficulty. And so that's the piece of work that we try to aim at. This is a somewhat dense slide. but it has many pieces of useful information, because what this does is talk about a national study of LGBT older adults that talked about reported high levels of disability and depression for folks, that 2/3 have histories of having been victimized in some way over their lifetime, 13% having been denied health care or received inferior care, 21% not disclosing sexual orientation or gender identity to their physician, withholding a significant element of their identity. This data is a little more recent than the previous slide, so this shows 25% do report having children and 15% have grandchildren. So here's the other thing to keep in mind. For many LGBT older adults, they were in heterosexual marriages earlier in their lives, that there was a sensibility if they were coming of age in the 50s, 60s, and 70s. All right, I'll give it a try. Everybody else is doing it. This is the way to kind of get along, to sort of live in the world. And so many did marry someone of the opposite sex, somebody, and have had children, and then in 60s, 70s, or 80s may have come out, ended those marriages, come out. And so there very well may be adult children and grandchildren. And so again, not to make the absolute assumption that you are engaging with somebody, and if they say that they are an LGBT person, that there aren't any families. You still want to be able to explore kind of what's the nature of that relationship and engagement. And that in terms of resiliency, that we saw that there was a very high level of folks who did feel good about belonging to community and who were engaged in wellness activities. So I don't want to just create the doom and gloom, because many of our folks are really sort of vibrant and active and yet concerned about sort of these other elements. Really quickly, I think the film sort of illustrated a lot of the historical pieces, but I want to sort of take a look at this with you. One of the things that we know as social workers is that we need to be conscious not only of the person that we're meeting, sort of, meet your client where they are in this moment today, and that frequently in elder services we meet people in crisis. Mom is being discharged from the hospital this afternoon, and we'd really like you to send somebody lovely to her house by 5:30 to make her dinner and help her over the weekend, which, by the way, does not work that way. But that is, in as much as we're meeting that person here today, to realize that their life experience very much impacts the engagement that you have with them today. And we know this for lots and lots of obviously different populations, but to be thinking about it for the LGBT person, and particularly I like to emphasize this message because some of the work that I do is, as I said, between the mainstream community and LGBT, but it's also within the LGBT community itself as an intergenerational issue. We have had so much tremendous culture change that it's important to think about what people's previous, and we live in, the bubble of Massachusetts. So some people are like, well, so you're gay, whatever, my aunt's gay, my uncle's gay, everybody I know is gay. Well, it's no big deal. So let me just tell you about the deal, and you determine if it's big or not. So if you look at Anna as sort of our older adult, who is, 83, 84 at this point, she was born at a time when no school of social work would have somebody come and have a conversation like this. No place would. If it was, it would have been framed within the pathology, within both the medical and the social, the religious, the political and legal pathology of homosexuality as a deviance. And so she came of age at a time where nobody was talking about this. There was no sense, as our friends in the film talked about, no sense of anybody else out there like me. This had to be a secret. You were going to risk losing your job. You were going to risk losing your family. And involuntary hospitalization, all sorts of stuff. It was a high-risk situation for folks. Anna was 39 years old when the riots took place at the Stonewall Inn, which is sort of thought about as being the watershed birthplace of in the 60s of the gay civil rights movement, which was actually led by many transgender and cross-dressing people at a fairly routine police raid, because at that point, if you went to a bar to hang out with your friends and the police showed up, you could be hauled off and taken down to the police station, and your face gets in the newspaper and you lose your job and everything's downhill from there. That's for going out with your friends. So she was 39 when that happened. She was 43 when the American Psychiatric Association removed homosexuality from the DSM. So up until that point, by virtue of going to the doctor with the bad cold and the flu, and they say you're really contagious, who do you live with that might have been exposed to this? My roommate, my friend. Because if you said my partner, oh, now we have another diagnosis for you. You have this psychiatric condition of homosexuality. She was in her mid-40s when we saw a lot of culture change taking place, with Harvey Milk being elected as the first publicly out legislator. And then within the year, he was assassinated. So we had this sort of one step forward, one step back. She was in her 50s when AIDS was taking over this country in a terrifying and unknown way. And it's hard, again, to remember that at the time, we did not know how this gay plague was conveyed amongst people. We didn't have the knowledge, and when you have less knowledge, you have more fear. She was 67 when Ellen came out on her sitcom show. For those of you who actually remember it happening, it was a huge sort of culture. Forget this Robin Roberts stuff on Facebook and Twitter or whatever. This was a huge, huge deal. She was 74 when marriage equality came to Massachusetts a decade ago. And even since then, we've now seen the repeal of Don't Ask, Don't Tell. We've seen the Defense of Marriage Act change. So that is an enormous amount of culture change to live with. Compare her to the baby boomer of Sarah, and look at her developmental life stages when these same events took place. What does it mean for the DSM to remove homosexuality when you're 23? As opposed to when you're 43? What does it mean for marriage to become available and legal when you're 54? It's very, very different life experiences and very different sort of getting marinated in the messaging that the culture receives around these things as well. So one of the things that happens is that for a lot of folks, with so much of this really embedded institutional discrimination, comes this sense of distrust of a lot of the institutions that many of us as social workers really want to kind of hold in that traveling bag that we take with us when we work with people. And they're like, oh, you need housing? Great, housing. Here we go. I've got you on a housing list, and I'm doing this for you. Let's put you on that, right? That these are, even though they're the places that we think of as the go-tos, that for many of our folks, the go-tos were also places of oppression. So, and this happens in many other cultures as well, and maybe some of our speakers later on will talk about it. Many of us are raised to say the police are your friends. If you're in trouble, call the police. For many subpopulations, the police are not your friends. The police are actually the people who didn't respond to a police call or said that you deserved it or wouldn't respond well. And so that's a mixed message when we're talking with someone who may be experiencing domestic violence and we say, we want you to call the police if this happens again. And you've had an experience where they're as disrespectful to you as anybody else. So realizing that people have had those institutional experiences very much impacts how they respond to you as representatives of those institutions. And so in many ways, we have the added burden of overcoming that history and to convey a new experience, a new message for folks. So one of the things that's really important that I want to emphasize, particularly from sort of today's world perspective, is to understand that for many, many folks, given history, given kind of the world in which they live in, that being invisible really was the best coping mechanism that existed. It really was the smartest thing to do. Show up for work, do your job, go to family holiday events by yourself, or bring a friend, and don't draw a lot of additional attention to yourself. For many people, they would say, oh, I'm really excited about my summer vacation. My roommate and I are going to the Cape. Anybody want to decode that for me? Anybody? My girlfriend and I are going to Provincetown for the week, and we're really psyched. Okay. So, but that's the way you lived your life. There was this tremendous dichotomy between the private, secret life and the life that you live out in the world with other people, because there was a lot at risk. There also was, for many folks, then this small circle of who do I really trust, who really knows me, and the impact that that has on folks. Also recognizing, particularly for those of us, regardless of where we're encountering, if we have the privilege to do home visiting to people, or if we're working in some sort of residential environment where we want people to feel at home, that to understand that for folks who have to spend so much time acting as if, that the ability to come home and to be safe at home is profound. Home is where there is no closet. Home is where you can wear the clothes that you want to wear. You can have the artwork, the photographs up. You can watch what you read. That's where you are you. And so in previous parts of my lives, I was a case manager. I would go do a home visit and just call a client. And they'd be like, oh, dear, you're coming over to visit. Let me just straighten up the house a little bit before you come to see me. Don't do that. I'm coming for services. If the house is too clean, you don't get anything, right? But for that, for some people, straightening up the house is about putting photographs away, is about turning books around in the bookcase. If you ever go into a house and the title spine of the book is turned around, just saying, you might want to know why. Not just sloppy housekeeping. That it really is this idea of I need to protect myself even in my own environment because I don't know who you are as the visiting nurse, as the social worker. And that some of the messaging when, people are working in assisted living and they say, you're going to move in here and we're so thrilled, or senior housing, and this is going to be your home. And you may not have all the space, you're going to downsize a little bit, but we very much want you to know this is your home. Really? So, I've been talking to people who've been, I haven't seen these exactly, but people particularly in memory disorder units are creating memory boxes outside of residents' rooms where there are things that sort of illustrate who they've been and what's been important to them in their life. It's a wonderful idea for people with memory impairment, for the staff to see those other elements of who that person is, not just the patient of today. But when you invite me to really put myself in a memory box in the hallway, am I really safe? Can I really put pictures up of myself and my friends, of myself and my partner, my spouse? Is my life really going to be on display in a way that's safe and okay? Or should I put up pictures of sort of myself and then my dog and my cat and beaches and, the things that don't offend anybody? So even when we're saying, in an authentic way, come and be yourself, you want to think about whether the environment really is a safe place for folks, because that's what LGBT folks are thinking. So we talked about this a little bit, about the pathology of identity and the fact that for many folks, and many of our folks talk about their experiences having been in treatment to cure and to change themselves. And they bought into that. I need to be changed and fixed. And that we know that even though, the rule book may have changed in 1973, that does not mean that clinicians woke up in 1974 and 1975 having rid themselves of all previous conceptions. And we see some of that kind of change taking place right now, where we've had, for transgender folks, gender identity disorder as a diagnostic category. And in the new DSM, we now have a transition to saying that gender identity disorder as it exists objectively is no longer a mental disorder, but what people may present you with is gender dysphoria. I don't like the situation that I am in. I am not comfortable in terms of my identity and my body and how they do and don't match up. That's the dysphoria. But if I come in and say to you, I'm a transgender person and life is good. I like my job, I like my friends, everything's going fine. Maybe I've had a loss in the family and so I'm sad and depressed and I could use some counseling for that. I don't have a disorder. I just have a fact of life. But it's going to take us all time to unlearn a previous mindset. We also know that there have been higher incidences of mental health issues for LGBT folks across the lifespan in terms of suicide, anxiety, depression, substance abuse. But what is important to know is that those differences in outcomes disappear when you control for poor social support and coping skills. I think I'll talk about, I'll jump to this other point later. It's about the experience of how you are treated in the world that contributes to these factors. It's not just simply by virtue of how you were born and who you are. I'm now going to hit on a couple of topics really, really quickly. I don't want to give them disservice, but I just want to sort of drop these in front of your minds to think about. One of the things that I want you to leave here knowing, if you didn't know already, is that by the year 2015, which is frighteningly next year, I've been saying this for a decade almost, 1/2 of all of the HIV cases will be in people 50 plus. This is not a young person's disease. We have two things happening. One, we have many people who are long-time survivors of infection. This is not the death sentence that it was early on. And I was at a meeting not long ago with a man who said, I'm 63 years old. I was diagnosed with HIV when I was 36. And I don't know how I got here. I did not expect to be alive. All of my friends have died. I have many medical conditions. I don't feel like I'm 63. I feel like I'm 73 or 83. And I have no concept of what it means to be an old person because I never mentally thought about myself living to this point. Now what do I do? Very, very important to think about, as well as new infection rates and the fact that we are not thinking about sexual activity and transmission and targeting any of that messaging to older adults. And this is also important. This is, I think in the LGBT community, there's been lots of this messaging, but I think that in the heterosexual community, that we have not targeted this because, there is no sex after 60, right? We don't think or talk about sexuality in older adults. Don't even tell me what is and isn't happening in assisted livings and long-term care, because it's not happening if we don't see it. And so if we're not educating folks, we are actually doing a disservice to a population of people who did not receive the kind of messaging. If you are talking to a 75-year-old woman who was married to her husband for 50 years and she has a bunch of kids and grandkids and the husband dies, she meets a lovely man at the senior center who drives at night. He is going to have a lot of friends. Anybody in the room want to sit down and talk to her about using a condom and safer sex? Anybody? Look, one brave one. All of you, get that phone number and make all your referrals, right? We need to be able to think about this. Her doctor, who has 15 minutes to talk to her about her high blood pressure and wearing a helmet when you ride a bicycle and taking all those healthy aging courses and her blood, all that kind of stuff, is not thinking that I need to ask these questions. And when she shows up and she says, I'm reporting symptoms of fatigue and not feeling well, and I think I have the flu and blah, 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 they're going to run a bunch of other tests for did you have a flu shot, blah, blah, blah. And no one is going to even think that she's at risk or that she could be infected. By the time she is diagnosed, she is in a much more advanced stage of the illness because it just didn't occur to anybody that that might be what's at play for her. The other thing that we know about HIV and AIDS, and that particularly in the LGBT community, is that we developed really strong and effective caregiving networks and systems because we had to. And so many people, as the sort of boomers are aging in the LGBT community, are also saying, how do we replicate that? What did we do and build the first time that we can then try and do a second time? And so as we talk about issues around caregiving, it's important to think that we have a model for that already. I want to say something quickly about bisexuality because it does tend to be the most invisible letter in this alphabet soup of ours. Basically because your identity is based on the assumption about sort of who you're standing next to and partnered to. If I'm standing next to a man, you're going to assume that I'm heterosexual. If I'm standing next to a woman, you're going to assume that I'm a lesbian. The duality of this identity gets lost based on who you're standing next to or obviously partnered with. and that there's a lot of stigma and negativity that comes both from sort of the general population. You have sort of the Woody Allen's, bisexuality, twice as much of a chance for a date on Saturday night kind of attitude, or you're on the fence, you're promiscuous. But even within the gay and lesbian community, there is a lot of stigma and bias that's like, just come out already, stop with this wishy-washy business, or you know what, I don't really trust you. You could leave me at any time, and you could leave me for a man instead of for another woman. And so having this sort of sensibility, even within the sort of rainbow umbrella, people are still feeling very stigmatized and very much like, well, where do I belong? How am I even welcomed and accepted? And what assumptions are people making within our own community as well? So elders of color, we want to, people have multiple identities. We all have multiple identities. And so thinking about particularly for elders of color who have had a lifetime, when I was talking about sort of the mental health issues, I was thinking, and this is the slide that talks about minority stress. And minority stress, as we know, is the actual stress experience of living as a marginalized or minority person in the larger culture. Pick any of the various ways in which any of us might be a minority in a larger culture. And to think about, for elders of color, there has been the lifelong minority stress of being a person of color in our culture here. And then think about, what does it mean in terms of the relationships between the various identities that you hold? So what does it mean to be an LGBT person in a community of color? There's been lots of talk recently also about Robin Roberts and having come out, and homophobia in the Black community, and why it took her so long to do all sorts of stuff. But what does that mean? And what does it mean to be an old person in that community, which is really important? And then what does it mean, conversely, to be a person of color in the LGBT community? As you saw in the film, Lawrence is the man who was caring for his partner, Alexander. They're an interracial couple. What does it mean? Where is your identity? Where do you belong? And what does it mean to be old in the LGBT community? And what happens to all of us, regardless of that intersectionality, when we hold both sort of positions of majority and power? I'm a white person. I have majority power in that way. I'm a woman who may then have less power in our culture. I'm Jewish, so I have a religious minority. I'm a social worker. We'll keep going. I'm a lesbian. I'm a vegetarian. I'm a mother, blah, 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 right? So how do all those pieces fit? And where do we ever sort of think about how we internalize that sense of identity for when we're in and when we're out? Not that out, but, group membership out. Little o out. Transgender issues obviously speak to this as well in terms of the sense of belonging in the community. There's a long history of whether transgender folks belong under the rainbow umbrella with sexual orientation. And for many, many people, transitioning in their lifetime, if it was earlier in their lives, really did mean giving up a tremendous amount in order to be authentic to themselves, living a much more marginalized life, not being able to necessarily be working and living and keeping family connections in a way that most people would ideally like to. And that for some people, even to the point where they had to I sort of think of it as kind of this witness protection program model, where you need to really cut ties with your previous life and move on to a new place where you clean slate, start anew in your new identity. And that there are also many people who wait and who want to transition later in life. They want to wait. Many folks who do will talk about transitioning after their parents have died. And so you may be waiting into your 50s or 60s or 70s because what am I going to do with my parents? How am I going to explain this to them? Will I be rejected by them? Maybe it's after your spouse has died. Maybe it is after your children have grown and left the home. Maybe it's after you've retired and you, A, don't have to worry about the fallout at work, and B, you've saved enough money because this is a costly thing. for people to undergo such transitions in their lives. And so for lots of trans folks, we see that there are historically high rates of unemployment, underemployment, violence, and having been denied health care. And that's one of the pieces in the film. Chris Ann, who is the woman who is being treated for lung cancer, the issue particularly for the trans community in relation to health care is really powerful and significant. That there is a sense of, is there a place that I can go where I will be safe and I can trust my providers and I will get respectful care. So the stories from trans folks who have been violently beaten on the streets, and when EMS is called, the responders say, oh, hell no, what's that he, she freak? I'm not touching that. I'm not picking that person up. Or maybe they make it to the emergency room, at which point the nurses are like, oh my God, Paul, come over here and look at this. I've never seen anything like this before. Have you? While you're lying on a gurney with the little cotton thing pulled around you in an emergency room. To whatever levels of feeling like you're going to be disrespected, you're going to be mistreated, and that you might actually be abused and neglected simply by virtue of who you are. And so understanding that not wanting to accept even just something like personal care, having assistance with dressing, with bathing, engaging in any kind of medical care can be really quite anxiety-provoking for folks when they don't feel like they have a safe resource. I'm going to go through these really quickly. So Defense of Marriage Act, which was in place for a very long time and which was struck down this past June, and supposedly the gates are going to open and the world's going to be, everything's going to get better. For many of our folks still, they are living with the consequences of the discrepancy between federal law that does not recognize their identity and their relationships and what for the past 10 years in Massachusetts we've had in terms of marriage equality. And so if you lost your spouse 3 years ago, you're still living with those ramifications of the distinction between state and federal recognition of your marriage, regardless of what the future holds for us. And that for many people, there's still, for the decade that we've had in Massachusetts, folks have been able to say, I'm married here in Massachusetts, but the feds are doing, are not recognizing my marriage, and how does that impact me in terms of I don't get Social Security benefits from my spouse, I don't get, I'm not recognized as a next of kin, all these other issues. Now what's happening is that the feds may be in a position of recognizing you, but that if you were thinking about retiring to Arizona or to Florida, you will move somewhere where the feds might recognize your marriage, but the state won't. And so we still have that discrepancy that exists. The other thing that's really, I have to stop talking. The other thing that's important is to be thinking about healthcare decision making, which again, everybody, regardless of your age, this is not just for old people, everyone needs to think about how we designate someone else to stand up for us at a time when we're not able to make decisions for ourselves. But that we have a traditional system that says that, without somebody legally identified otherwise, we look to blood or we look to marriage, and the kinship that is established that way. So what happens for folks whose primary people are not covered? You are not legally married to me in whatever environment we're in. Or you are not my blood family, and yet you are the people who really know me best. When we talk about caregiving particularly, it's an interesting distinction to look at the general population and LGBT folks. And this is important because many of you actually, as we're talking about these issues, may be encountering sort of the midlife sandwich generation caregiving folks, more so than the LGBT older adults themselves. So what we know in general about caregiving is that primarily in this country, most caregiving is provided by women who are providing that care to someone who is related to them either through birth or marriage. So most likely it's going to be the daughter or daughter-in-law, sister, sister-in-law, granddaughter, wife, something like that, that is providing that care to that established, familiar, traditional family network. What we know in the LGBT community is that we have a much more parity between both men and women acting as primary caregivers for individuals, and that only 60% of that care is delivered to that traditional network of family, partner, spouse, that kind of thing, but that 40% of that care is delivered to non-relative or friend. So, why is that? How is that? What does that mean? Why are LGBT folks more likely to be taking care of their friends? Well, I think it speaks to something that is important in the LGBT community, which is this idea of families of choice. Amistad Maupin talked about biological family and logical family. Discuss. No. So there is the idea, and sort of, so if you look on the left side, this is sort of most of the idea about biological family, but that particularly for LGBT folks for whom their biological family have not been a source of connection and support. Many people have moved away. Many people have had strained relationships because of their identities. That LGBT folks have historically created families of choice. These are the people who know us best, with whom we spend most of our time. They're our go-tos. And I think that it is, again, one of those touch points for thinking about how we redefine family across the board. In every population, we need to redefine. The traditional mom and dad and the kids model does not exist in the enormity that it did historically. And so we need to rethink what family means. So it may be that this 32% of friend may be an ex-partner who's not a current partner. It might be someone who's been your best friend for 25 years. And the people who know you and know what you want in a much more real and authentic way. I know a story of somebody who was from California, came to Boston for school, was a gay man, and he died unexpectedly at a relatively young age, and his family sort of came in to take care of everything, right? The apartment and the home and the services and all of that. They saw him once a year at Christmas. His best friend who lived here knew him, knew what was important to him, knew all of the sort of details. Now, this happens in lots of family situations. Lots of relocation, lots of connection, functional and dysfunctional families. So we don't own this in this way, but it has been a particularly important sense of identity. And so when we look at those numbers, it really is about thinking about family of choice, thinking about who are folks choosing and identifying as their family. It's also important because much of LGBT caregiving is considered to be horizontal rather than vertical. And what I mean by that is, again, in this sort of general population vision, we have the daughter who's caring for her mother and may have grandchildren who are helping. So last Friday with the big snow, if grandmother was snowed into her house and needed a prescription filled at the pharmacy, maybe daughter, maybe granddaughter goes and shovels her out and gets themselves to the pharmacy and delivers it, right? In a horizontal world, most of us have friends who are probably within about a decade of our own age. And so that elder who needs the prescription from the pharmacy has now got to call their friend. The elder's 78, might be calling a friend who's 68, and maybe their balance isn't so good, maybe calling a friend who's 82, whose vision isn't so good to be driving in bad weather. And so how are we going to get that? Because if you lose that horizontal cohort, you don't have the support of, a wonderful 19-year-old grandchild who's like, oh yeah, no problem, I'll throw on a sweatshirt and go to the pharmacy and I'll be right back. So cultivating some of those, all of you go out and get much younger friends, unless you're currently in your 20s, at which point it's kind of weird, but wait a while and do that, because again, those are the kinds of things that we don't think about because we make those assumptions, but what happens to us with that kind of horizontal. So one of the things that we do at the Aging Project is that we offer an LGBT caregiver support group. It meets once a month in Jamaica Plain, and it is a place where people can talk about the experience of being an LGBT caregiver. So lots of folks will also go to the Alzheimer's Association and go to other places to sort of get support on the caregiving tasks. This is the place where folks can talk about, I'm an only child. My mother kicked me out of the house when I was 16 because she found out I was gay, and now she's in terrible shape and I have to take care of her even though she's never done anything nice for me. And again, we hear this in lots of other family systems, but what does it mean in terms of the currency of being an LGBT person? The other thing that obviously comes after a caregiving experience very often is bereavement, and that if we don't have recognized relationships, that the grief subsequent to that is disenfranchised and can become quite significant for folks. We offer LGBT bereavement groups. They're short-term 8-week groups that we offer. They have primarily been filling up around partner loss, which has been interesting, although we have had people also coming for other friends and family members to, again, have a safe place. And much of this is prompted by a presentation that I gave when a social worker in the audience said that she had been working with a gentleman who just lost his partner of 35 years. And when she called for a grief group, a support group for him, the other social worker who responded, I don't know how you get someone's license revoked, but anyway, responded and said, well, you know, as long as he doesn't talk about the nature of his relationship, I think he could be in the group. Bereavement group. How do you not talk about, who, oh, well, my friend died, and now I don't know what to do about cleaning out the closet. Well, I'm so used to waking up in the middle of the night and worrying about my friend. I mean, it just clearly was a disconnect and clearly not and you know, what I felt at least relieved is that this gentleman didn't get this slap in the face himself at this most vulnerable point when he really needed somebody. And it could have been a wonderful opportunity where, you know, some heterosexual woman would go, oh my God, I did the same thing worrying about my husband. You know, I would wake up at 3 a.m. to see if he was still breathing. I mean, there could be that wonderful connectedness. But that opportunity was not there. So we create those places for people to have that safety to say, I don't know how to be on my own for the first time in 20 years. What do I do? Couple of things for you all to think about in terms of your own practice, what you can take out today. Challenge heterosexist assumptions. It sounds like a midterm for your sociology test or something, or for HBSE. Don't assume everybody's straight. It's really hard to do. We are all marinated in a culture that assumes heterosexuality unless proven otherwise. But think about if you didn't assume heterosexuality or gender conformity for every person that you met, how would your language be different? How would you say to somebody, you know, do you have a spouse? I don't have to ask you if you have a husband or a wife and call that out. Expand, as I've said, expand those definitions of family. Don't just sort of say, you know, do you have kids? Because maybe it's not children, maybe it's nieces and nephews who are the significant people in someone's life. And prepare for possible backlash, that there may very well, as you think about being more inclusive in how you're talking, if you said to somebody, I have a friend who's a family practice doctor, and so when he talks to folks, he says, are you sexually active with men, women, or both? What kind of freak do you think I am? Why are you asking me those questions? My God. You know, think about how you're going to respond to people who take offense by your opening with a broader kind of thinking about who might be in front of you. Really quickly on language. Language evolves and changes over time. Some of our folks continue to use homosexual, which is very much sort of this archaic medical term, but may talk about a friend, a lover, a partner. Some people are using husband and wife. Still lots of people who are talking about roommates, and I have a friend, and thinking about what language they're using and trying to mirror that in whatever way is sort of most attuned to where they're at. You don't want to sort of push somebody with language they're not comfortable with. The other thing is the word queer. I said it really loud because this is a word that really has been reclaimed by a younger generation. And queer students and queer eye for the straight guy and all sorts of queer stuff all over the place. And it's really a lot easier than LGBT, all the letters of the alphabet. However, I never use this term with my folks. This was the word that their generation heard before they got the stuffing beaten out of them, before they were chased down the street, before they were kicked out of their families. And so unless they are actually using the language, I don't presume to use it with them. So again, it's this intergenerational piece about thinking about we're not the LGBTQ aging project. We might be in 20 years, but right now we think about sort of where our folks are at and what kind of language. Also the importance of being an ally. If you are not an LGBT person, but you stand with this community, your identity as an ally is really powerful. And I don't want to miss out on that opportunity to actually name that, because it's very important. Other things to be thinking about also is about using more open-ended. I mean, this is sort of good clinical training, right? The closed yes or no questions. Are you married? Yes. Great. What do you know about me? Right? Tell me a little bit about, who's important to you in your life. I meet lots of people with different kinds of families. Tell me about who's important to you in your family. Well, let me tell you about my 6 cats and my 4 dogs and, all those kinds of things. That's not necessarily what the boxes on the paper are going to be asking you, but those are the things that are going to help you understand and know, and will convey, from your perspective, an openness to hearing. Right? So when my friend says sexually active with men, women, or both, he's already given the menu of options, and you do not then have to come out in an uncomfortable way to correct somebody. And that's really important for people. And also even to just create an affirming environment. So to say if, gosh, Gina, I'm picking on all the people up front who I know. Gosh, Gina, you're telling me about how you and your roommate you've been roommates for 25 years, and you guys are a great team. You're so lucky to have each other. And I just think that's terrific. You do a good job taking care of each other. And it must be so hard that she's in the hospital now, not doing all those things around the house that you're used to. I didn't out you. I didn't say that it's your childhood best friend. I didn't say it's your long-term partner. I didn't say anything. I simply conveyed that I recognize this was an important, significant relationship and not just somebody who splits the rent with you, and that it's not invisible. And that can be really important at a time when people aren't using that kind of language with you. Organizationally, make the effort to create inclusive environments. Enhance your capacity. You're already here, so you can check that off, although you're not done when you leave. And to strengthen those collaborations, to create programming, to do outreach, to actually be clear and explicit about making efforts to reach out to LGBT folks, whether they're older adults, whether they're younger, whether they're caregivers, and to convey that message that LGBT folks are welcome here. More often than not, I tend to meet people who are like, oh yeah, we're very welcome, our whole team is great. And I'm like, how would I know that? If I picked up your flyer, if I found you online, how would I know that this is a safe place? What did you do to convey that message to me? In your messaging, in your materials, in your mission statement? How are you going to let people who start from the position of not knowing whether they're going to be treated safely and respectfully, how are you going to convey that to them up front? Oh, okay. How are we for time? 15 minutes, I think? Oh, yippee. Okay. So I've done a lot of talking at you, lots to kind of think and percolate on. What I would love to do right now is to hand out a couple of scenarios to one scenario to each table, but we've got different scenarios at different tables, to just let you and the folks at your table think a little bit about what you would actually do. Now that we've sort of got you thinking, let's do a little bit of doing. And to realize that there is no one singular correct answer that your table needs to come up with in consensus. Everybody has their own personal style, and so you may find very different responses based on those scenarios. So take about 10 minutes, I think, to chat with the people at your table, introduce yourselves if you don't know each other yet, and spend a little time with that, and we'll walk around, and I'll walk around and sort of eavesdrop a little bit, and then we'll all come back together and talk as a group. there were, I think, about 4 or 5 different scenarios that were out there percolating, so you've all been thinking and talking about different topics, but I'm wondering if anybody wants to just sort of share generally your response from your table or amongst one another to the issues that were kind of placed in front of you, those real-life practice skills, something that struck you or surprised you as you were trying to figure it out. Dead silence. I heard you all talking. I know you had conversations. I listened in. They were good. Did your whole table just agree you were all going to handle it the same way? Everybody on board? Thank you, sir.
I'm Kevin McCarthy. I'm a social work student. And there were a lot of different things. I think the first concern was, this is an 85-year-old lady, and she just came at you pretty hard. You know, do you want to give her a beat down? The first, someone said, can I hit her?
That's a clinical term, beat down. Yeah.
So then we sort of tried to take a better spin and look at it. But a lot of it, what we talked about was the fact that, you know, here's a person who has had a life history and a pattern, and are we there to change them, or are we there to just offer them something? And so a lot of our conversation was about, how do you spin to her the open opportunities? One person I thought was a great response was, oh, so I see you've read our newsletter. You know, and so there was something there. There was something welcoming. There was something engaging. And then the conversation actually turned to disclosure. Do you disclose yourself? Do you try to identify with her? And all the different options that we have and some of the choices we have to make as clinicians. Was it important for one of us to say to this person, well, you know, but I'm a heterosexual and a normal kind of person, you know, or was it important to validate her opinion and her perspective, and then say, yes, we offer services for all types of people. I'm sure there's something that this community center has that you could partake in that would make you comfortable and make you enjoy. And I think that was sort of the discussion, is how do you do that? How do you respond? But the most important question for me was, how do you feel inside? How do you feel? How do you as an individual, whether you're heterosexual, LGBT, how did you feel when this woman said this to you? And how is that going to impact your response to her? So that was sort of the depth and breadth of our questions.
Great, thank you. Anything else about this? So this was a scenario, obviously, about a woman who you're doing a visit and assessment to, and she says, oh, you're from the senior center. Well, I read you're doing all this LGBT stuff, and that's wrong. Those people, why are you doing this? And the backlash piece. And sort of how do you respond both as an individual and a person to some kind of backlash? Are you one of them? Why are you doing this? Why? And also as a representative of an organization, how do you respond and say, you know, we're really dedicated to providing care for everybody, and we serve all different kinds of folks. So let's talk a little bit more about how we can be helpful to you. Oh, you read our newsletter was a brilliant response. You know, that acknowledges, because one of the things is that folks are entitled to, you know, diversity doesn't mean you agree with me. And you are perfectly entitled to think that, you know, gay people are going to hell. It's on you. You can believe that if you want to. And in community, how do you engage with other people when you're talking, you know, is this going to be an issue between you and the person that you work with? And how do you still provide that care for someone? Any other thoughts about a different scenario or, yeah?
Thanks. I'm Jessica Goldrich. I'm a MSW student, and we had a case of an older gentleman who we're visiting, and he's going to need a personal care assistant, and he just wants us to make sure he doesn't get a fag to bathe him because he has concerns about that. And so we had an interesting discussion about our own internal disturbance with that type of comment that we found to be hurtful and offensive. And we also had thoughts that maybe he might feel that being bathed is a sexual, potentially sexual kind of an experience, even though we may not see it that way, and how he might feel vulnerable at the thought of being bathed by a man. And we also talked about his terminology may be a sort of a norm for his world and his subculture, even though we find it to be rather sort of something that should never be said. out loud. And we also talked about the possibility that he might be gay. And he might be afraid of being outed by a gay man who can see that he's gay, or someone else said by a neighbor who sees a man coming in to take care of him. So we don't want to assume that we know his sexual identity and what he's dealing with. So we talked about the importance of addressing that comment. So tell me more about your concerns. To try and explore that, because there might be something there that his son just came out yesterday, or that he is gay and he's afraid of being outed, or whatever it might be, and not to assume that we know what that comment means.
Excellent. Great job. The other thing is that he may not have gotten the memo that we've updated our vernacular, right? My mother still wears dungarees. It kills me. Right? So maybe he's like, oh, don't send me a fag, when you're like, well, actually, we now tend to, so sometimes it's assumed good intention. You can figure out the tone of how it's presented to you. But so sometimes, people read that and they're like, oh, that's terrible. He's a bigot. He's biased. He's an intolerant, blah, blah, blah. He just may be using old language. And so thinking a little bit about that and what is our gut reaction to it, and what is he saying? Maybe he has a sexual abuse history, and so the idea of having somebody have contact with him personally is really frightening. There's sort of all sorts of things under it. Sometimes that provocative piece can get us caught and can get them caught. So I think you all did a nice job of trying to tease that out a little bit more. Any other thoughts either about other scenarios that you had to deal with, or anything else from either the film clip or any of the million things that I touched on when I was talking earlier? Yeah.
I work with youth, and in schools there's tons of safe space stickers and this and that to identify that your classroom, your office is a safe space. Is any of that carrying over into like the elderly population?
So it's a great question to say, there's been a lot done with youth around safe space and about gay-straight alliances in schools, and sort of how do we create and communicate that. And so we haven't yet sort of created a kind of lavender rainbow label of some sort like that. But we've, had conversations about that. I mean, some of the places that we've done work with have actually put a rainbow sticker up at the front window of their organization, or they might put something in their materials. So some of the individual providers that we've worked with have actually chosen to put a rainbow sticker in their office. And so it's not as institutionalized as some of those safe spaces is, but again, it's a way for somebody, a lot of the folks in the hospitals now will wear a small rainbow sticker on their ID tag. And again, is it done by choice? Do people just, you individually choose to do this? Is it encouraged generally? And are those people ready to sort of talk about the backlash piece of it? If someone says, why are you wearing that rainbow? Are you a fag? We're back to the fag thing again. But, but that's a great point about how do we let folks know sort of who is and who isn't safe. Any other? So the one other thing that I'm not sure I said explicitly that I think is important is that as we're talking about these issues and we're talking about LGBT older adults, it's also important to be thinking about the LGBT caregivers of older adults. So you may be, you might work in an assisted living, and really, really, really every resident of yours is a heterosexual person. Really, really, right? However, they may very well have a trans adult child who's their caregiver. And so how is the staff responding to that? That how are you thinking about being inclusive, not just for your identified patient, client, consumer, participant, but for the other people who are in their constellation? There was, and I think, is that one of the scenarios I think that other folks had about the mother who was very disturbed about her daughter? Did I give that? Okay, there were people back. So, again, in this scenario where you go see an older woman and she tells you that her daughter just left her husband and is destroying the family and doing this terrible thing, she's taken up with this woman. And so it's really about what do those LGBT issues mean in a family and how are they impacting that older adult. Because sometimes that we find when we begin to introduce some of these topics to that peer group themselves, that they suddenly have the opportunity to talk about their children, their nephew, their grandkids. in a way that they didn't even feel amongst their own heterosexual peer group that it was okay to talk about. So again, it's not just about the older person, but their life experience and the messaging that they have around LGBT older adults. So, okay, last chance for questions, burning questions. Okay, so you can also, I have a little bit of material that I can put on a table in the back if anyone needs to track me down. LGBTagingproject.org is probably the best way to find me, and folks here have my contact information. So I appreciate your attention and your participation, and hope that we have sort of offered up some food for thought that you will continue to digest and take forward with you in your work. So thank you.
So I just want to thank Lisa. This was really a great morning, and as we walked around, it was such rich conversations that you were all having at your tables, and I just want to put in a plug-in for Jen Silent. How many people have seen it? Okay, so there's almost somebody at every table, and you can just speak to how powerful this film is, how beautiful this film is. It's about relationships, it's about aging, it's about race, it's about sexual identity, but it is such a powerful movie. Can't recommend it highly enough, but you need to give yourself a little buffer when you're done watching to just decompress. You can't just walk out the door and go somewhere. That's my advice, to just be able to sit with it because it is really powerful. So again, just want to thank Lisa for everything that she did for us this morning.
Thank you.
Thank you.